Zavicefta, a combination of the third-generation cephalosporin ceftazidime and the novel non-beta-lactam beta-lactamase inhibitor avibactam that's effective against many difficult-to-treat infections due to aerobic gram-negative bacteria. Zavicefta is indicated for complicated intra-abdominal infection, complicated urinary tract infection, including pyelonephritis, and hospital-acquired pneumonia, including ventilator-associated pneumonia. Additionally, Zavicefta is also indicated for the treatment of infections due to aerobic gram-negative organisms in adult patients with limited treatment options. In this video, we're going to illustrate the effectiveness and safety of Zavicefta as a salvage therapy for the treatment of infections due to carbapenemase-producing Enterobacteriaceae in patients treated during an epidemic outbreak of OXA48-producing Klebsiella pneumoniae. This was an observational study of a prospectively collected cohort of 57 adults, most patients, where most of them received Zavicefta for a median of 13 days as monotherapy or combination therapy for carbapenemase-producing Enterobacteriaceae. Zavicefta was available for the treatment of patients who met one of these criteria. 1. Poor clinical course with adequate antibiotic treatment. 2. Contraindication or impossibility of use owing to unacceptable risk of toxicity associated with the use of other appropriate antibiotic options. And 3. Toxicity of previous antibiotic treatment. Regarding the main outcome variable in this study, it was mainly the 14-day all-cause mortality, while the secondary outcomes were 30-day all-cause mortality, clinical cure, and microbiological cure. On the other side, the main safety outcomes were occurrence of adverse events and/or development of resistance during or after treatment. This trial has shown some interesting results, where 57 patients were treated with Zavicefta. The most frequent sources of infection were intra-abdominal, 28%, followed by respiratory, 26%, and urinary, 25%. Of them, 54% patients had a severe infection. Moreover, the median increment CPE score was 6, and the score was greater than 7 points in 40% of cases. Bacteremia was confirmed in 46% of patients. And according to the microbiological profile, isolates were OXA48-producing K pneumoniae in 54 cases, Escherichia coli in 2 cases, and Enterobacter cloacae in 1 case. Zavicefta has shown promising results. It was started in most of our patients owing to failure of previous regimens, and the median time from the onset of infection until the start of Zavicefta was 5 days. And regarding the main variable outcomes, it was found that the only factor related to 14-day mortality was an increment CPE score greater than 7. Besides, clinical and microbiological cure were achieved in 80% and 67% of patients, respectively, when used as a monotherapy. About the main safety outcomes, it was found that recurrence of infection was observed in only 10% of patients with a median time of 41 days. These patients were retreated with Zavicefta monotherapy, and all but 1 patient were clinically and microbiologically cured. The remaining patient achieved clinical and microbiological cure following a 3rd course of Zavicefta monotherapy. Furthermore, development of resistance to Zavicefta was not detected in any patient during the whole follow-up period. In regard to treatment safety, 2 patients developed acute kidney injury during Zavicefta treatment, but discontinuation owing to side effects was required in no patient. Moreover, no other adverse effects related to Zavicefta were observed. In summary, Zavicefta shows promising results, even in monotherapy, for the treatment of patients with severe infections due to OXA48-producing Enterobacteriaceae and limited therapeutic options. The emergence of resistance to Zavicefta was not observed.